Welcome back to Quick Hits, the podcast where we explore the latest trends and innovations in healthcare technology. I'm your host, Tyler Smith, CEO of Health Data Movers, joined as always by Ken Booth. Today's episode brings you an insightful look into the evolving world of structural heart care with Dr. Nish Patel, Director of the Structural Heart Program at Baptist Health, Miami Cardiac and Vascular Institute. Dr. Patel's journey from growing up around chronically ill family members in India to leading one of the most advanced heart programs in the country is a powerful reminder of the personal stories that drive innovation in healthcare. In this episode, Dr. Patel shares how data-driven decision-making, cutting-edge tools like procedural simulations, and emerging AI solutions transform patient care and help save lives faster. We discuss the challenges of standardizing structural heart programs across complex health systems, the critical role of interoperability, and how Dr. Patel's team is improving the patient journey from diagnosis to treatment. His approach blends precision, empathy, and leadership and offers a clear vision for the future of cardiovascular innovation. We're honored to have Dr. Patel join us to share his experience, leadership perspective, and the technologies helping to reshape care delivery. Don't forget to subscribe to Quick Hits on your favorite podcast platform and enjoy this conversation with Dr. Nish Patel.
Welcome to another episode of Quick Hits. I'm your host, Ken Booth, joined as always by my co-host, Tyler Smith. Tyler, how are you today?
Ken, great to be here. Excited about this episode.
Yeah, I love how this podcast has introduced us to some heavyweights in the healthcare IT industry. This week, of course, is no different. I'd like to introduce Nish Patel, Dr. Nish Patel. He's the director at the Structural Heart Program at the Baptist Health Miami in the Cardiac and Vascular Institute. Dr. Patel, welcome to the program.
Thank you, Ken, and thank you, Tyler.
Well, Dr. Patel, before we get into our conversation, we here at Quick Hits just love to get into the background and find out how you became passionate about healthcare. What started you on this journey, and can you tell us what led you to your current position here at Baptist Health Miami?
Yeah. Thank you, Ken, for the question. So, I can start with why first I became a physician. I come from family of patients rather than having a doctor's. When people speak about what inspired them to be a doctor, most of the time you'll hear a story that a family member was a physician and that inspired them to be a doctor. But I was actually growing up in India, I was surrounded by family members who had diseases, and I would. Go along with them during the doctor's office visits and things like that, and uh, sort of staying around those patients actually wanted me to become a doctor in childhood. And I did my med school in India, and my whole family moved here when I was in my first or second year of med school. So uh, they moved to upstate New York, so they still live in Albany, New York. And I finished my med school in India because I was only paying $150 a year for my med school.
Wow.
And yeah, and then I chose medicine because that's always I wanted to do, and become a physician. And during actually my medicine residency, I wanted to do a GI or pulmonary medicine when I started my residency. But during the residency, you sort of have rotations with different specialty, and the cardiology sort of really intrigued me. And initially, I was more inclined toward electrophysiology. And when I started my cardiology fellowship, my first rotation of the fellowship was the cath lab rotations. And that instant gratification that you get in the cath lab when somebody's coming to the hospital dying with an MI, and you put a stent, and just in 60 minutes you change that person's life. Now that person can go home the next day and go back to their normal life. And that sort of changed my mind to go into interventional cardiology. And while I was doing my cardiology fellowship around that time also, the TAVR was being studied. In 2011 was the time when transcatheter aortic valve replacement, which was the catheter-based solution for aortic stenosis, became FDA approved, and initially it was approved for the high risk patient population. And around my fellowship time was the time when the intermediate risk patient population was being studied. So that sort of intrigued me to the structural heart space, and I knew that I always wanted to be something procedural based. Because there I could actually listen to the patient, find out what's the issue, then also manage it and give them some sort of solution which would improve their life. And majority of the procedure that we do are either making them feel better or prolonging their life. So that led me to pursue my structural heart disease at Mount Sinai Health System in New York City. And when I was doing my structural heart fellowship, that was the year when the low risk aortic stenosis trial, the partner low risk, and also the Evolute low risk trial were being presented at TCT meeting in 2018, I believe, November of 2018. And the other landmark trial was the COAP trial, which was the catheter-based solution for the mitral regurgitation. So it was a perfect time to finish my fellowship and get into the practice. And the leadership role was, that's sort of once you start practicing, and when your goal is to excel at whatever you do, that sort of come naturally towards you. That if you have that mindset of making sure that the excellence is the only choice that you have. And that's how I landed the leadership position at Baptist Health. And initially, I was practicing in upstate New York, but Baptist knew about me and reached out, and I came and see what their vision was, and I was attracted by their vision, and that's why I joined them.
Such a fascinating story. And Dr. Patel, having a sister who's a physician who came to it through a personal experience. She had scoliosis when she was in seventh grade, and that led her to really want to make a change in healthcare through a personal experience. But hearing yours of being around others, it's just such an altruistic origin story. And then, as we talk about vision and mission as you lead an organization, would love to hear about that more because you're leading a really highly complex and coordinated program. But maybe if you also can talk to us about those dimensions in addition to how data and digital tools help you drive decision-making, care planning, and outcomes in your leadership and also in structural heart cases.
Yeah, very important question. So, data is in cardiology space, that's the only space I believe in medicine where every single decision that we make is based on data, or some sort of really significant evidence. So one of the first point I would make is a majority of the decisions in the cardiology space, in the structural heart space that we make, are evidence based, which is data focused. And then comes into the data analytics and how data is sort of helping us make a decision in the patient care. There are a lot of one example I would like to give is today I just had a patient that we're going to be offering that patient an off-label therapy, which is off-label is whenever the therapy is not approved by FDA. We call it an off-label therapy, and those therapies are only restricted to the patients which are prohibitive risk for current standard of care. Um, so that patient has severe mitral stenosis, and usually that patients are offered an open heart surgery. But here we have these patients who have severe mitral stenosis but prohibitive risk for mitral valve replacement by the surgical approach, which is just standard of care at the moment. There, we're going to offer her catheter-based procedure, which is a transcatheter mitral valve replacement. Now, that procedure is FDA approved for the valve-in-valve for those patients who already have a valve, or valve-in-ring, which is the patients who have a ring in the mitral valve position, but not for the native valve. So there, we did the CT scan analysis, and then after CT scan analysis, we're gonna did the analysis on the 3-Menso, which is a software we look at to understand that we can put a valve in this patient without any significant complication, because it's an off-label procedure. On top of that, after doing my analysis of that CT scan, we're also sending that CT to there's a company called Darcy Simulation, which actually does computational simulation of the valve replacement procedure um, before we do the procedure. So essentially,
Cool.
virtually doing the procedure and
Yeah.
understanding that what sort of result that we're going to get, so that I am confident when I do the procedure that I'll be able to provide the best result for this patient, and it takes away sort of unpredictability of the procedure.
Right. So it's not just the data of it, yeah, the evidence, the past data, but you're actually doing a scenario type of planning.
Yeah,
Yeah, fascinating.
and that actually uh, adds to that patient cared approach or patient centric approach, right? Because we people talk about patient centric approach, but how do you implement that patient centric approach? Because you're sort of giving them the therapy based on the population based trials which are done, and now you have a patient with you know not a part of that trial but might have a lot of other things, and I think those kind of things would help the patient-centric approach.
Yeah, and actually, that's a really good segue into what we wanted to talk about you next. So, the individual approach versus the larger scale approach, and you know, it, there's obviously scaling and standardizing, which we're talking about now. And so, what are some of the biggest challenges in scaling or standardizing structural heart programs across systems or networks?
Yeah. So scaling and standard, I think this kind of thing, what I mentioned about computational simulation, can be standardized. The CAT scan is essential part of the procedure that we do, and most of these patients are getting CAT scan, so that's already standardized, and you can add a layer of that computational simulation to those CT scan, and you can get the result in about 48 hours. The bigger question is, how do you standardize in the health system? Sometimes it becomes difficult. I tell you, the Baptist Health South Florida has 12 hospital, and the structural procedures are being done at 4 different campuses, and different doctors are doing procedures at different campuses, and if also based on if the doctors are part of the health system or they are a private group which is practicing at the health system, that also plays a role in standardizing it. And believe it or not, you guys work in the data integration space, and even in those 12 hospital, we don't have the same EHR at every single health system.
Right.
I mean, every single hospital. Its health system is one, but it has 12 hospital. But all the 12 hospital may not have the same EHR. So
Sure.
that also becomes a challenge. And I'm sure there must be many health system in the country where this scenario might be present, where the EHR is different at different hospital.
Oh yeah. Well, and hence our raison d'être. But which raises a really important question is or I guess so. One point that I'm taking from your commentary is that you have to have standard or having a standardized patient record or standardized electronic health record is really important for this collaboration across sites. But in the meantime, yeah, how do you handle the challenges of incomplete data, or lackluster data exchange that can exist when not there's not full connectivity or interoperability?
Yeah, you sort of have to have uh, the manual process, which obviously is extremely expensive, right? You can have um, you can have people extracting the data and putting it in one place, and we have our data analytics teams, and they do that, but that's actually a manual process, and folks like you can help in that regard, I guess. And It's a challenge. I think it's a big challenge. When the EHR is different, and data are present in silos. Uh, just like echocardiogram report maybe somewhere else, the CAT scan report maybe somewhere else. Those kind of things also needs to be standardized, and Epic has done really well in that term, where all of the data at one place. I think Cerner is striving towards it, and but EHR, like Meditech and all, they might have a lot of issues. And one of the biggest hospital corporation has Meditech as their EHR.
Let's take a quick break. At Health Data Movers, we know that data migration isn't just about moving information from point A to point B. It's about making sure your clinical and operational data is accurate, accessible, and secure, so your teams can focus on delivering care, not chasing records. Whether you're consolidating systems, switching EHRs, or sunsetting legacy data platforms, our data migration experts help you move confidently through complex transitions. We bring proven tools, repeatable processes, and deep healthcare experience to make your migration seamless. If you're planning a system change or even thinking about one, let's talk. You can learn more at healthdatamovers.com. Now, back to the show.
So, Dr. Patel, you mentioned some really great points, especially when it comes to the challenges that these healthcare organizations are experiencing. For example, last year we were working with a large health organization, and we were converting cardiac reports. And just that one report created tons and tons of meetings. And what we discovered is that basically legacy EMRs used to think that the key was customization and let people kind of do as much as they wanted to. But then we're finding that to be a challenge converting into the future because there wasn't necessarily a standard. So the question is, how can people at these organizations start working toward a standard even though they don't necessarily have one yet?
Yeah. Um, I think I give you one example of how we're striving towards standardization. Because I've had Epic Cupid, which was a reporting for Epic Cupid has reporting for echo, cath procedures, and Holter monitoring, nuclear stress tests, and all of those reports are standardized report because they have generated a system where a different operator doing different procedure would have a report which looks exactly the same. So there's no variation in terms of how the report looks. And when I came to Baptist, we didn't have any standardized reporting. So we sort of created a template in, Nuance. Nuance has um, reporting system also, and there you can make your template, and for making sure that every single operator follow that template help us standardizing the cath reports or any cath procedure report. So every single individual's operator's report would look exactly the same rather than different variation of it, and it would also capture every single element which would be needed for billing purposes also, and also the registry, because many of the procedures that we do all of them are part of NCDR registry, which is a National Cardiovascular Disease Registry. So any cath procedure that we do, any TAVR procedure we do, any mitral valve repair, catheter-based mitral valve repair, all of those are part of registry. So we'll make sure that whatever the element which are needed in the registry are part of the report, so that whenever those folks which are entering those data into the registry, they don't have to go at multiple other sources to gather the information.
Dr. Patel, as technology gets smarter, AI, predictive analytics, image fusion, some of the examples you've given throughout our conversation already, maybe can you speak a little bit more about even other areas where you can foresee these tools transforming how you evaluate?
Yeah. So Tyler, right now it's an exciting time, and it's just a starting phase. You know, in structural heart space, some of the diseases that we treat, they actually have implication in terms of how long the patient's going to live. And if we wait on those issues, the chances of worsening the heart condition, having a heart failure, also having a reduction in the life expectancy. So major heart point issues are there when there's a delay in the treatment. So right now there's a push towards early diagnosis of these diseases. Now how can we do that? And that's where the large language model are actually helping us. So there are some tools out there. One of them is Ignite CardioCare. um, so that is essentially a large language based model solution where what you do is you actually share your data of patients more than 50 years of age of whole EHR, and they would run a large language model and then would tell us that in our EMR of millions of patients, how many patients are there with the severe, let's say, severe aortic stenosis or severe mitral regurgitation. And those diseases have major implication because they can cause heart failure, they can cause sudden cardiac death, and there are many patients in our EMR which are under our care but may not be in the front of right people.
Sure.
So that would help us, that it can tell us that, okay, on this week, these are the list of patients which are in your system who have these diseases but not being treated. So then you can whoever is taking care of that patient, you can send them the message that, okay, these are the patients, you have this patient under your care and who has this severe aortic stenosis, would benefit from evaluation by the specialist. And then eventually that patient would end in valve clinic and would get evaluated. Now, we know that severe aortic stenosis has 50% mortality at 2 years
Oh, wow.
once they're symptomatic. So these are the number like a stage 4 breast cancer prognosis number. So 50% at 2 years, so that means that every 15 days of waiting, you're exposing that patient for 1% mortality risk.
Wow.
Now, by doing that, if I'm able to diagnose or make sure that the patients are right in front of the person who's going to manage that issue, and reduce that diagnosis to the treatment, I essentially reduce that person's chances of dying and also having the heart failure in the future. So that's one I'm excited about, and that's also helping us in terms of diagnosis of the patient and recognizing that these are the patients who are already under our care and not being served.
Yeah, and it's really, well, it shouldn't be surprising, but how much speed plays a part. And I guess my question that comes up as you talk about that is, healthcare is notoriously slow for good reasons, in many cases. So how do you fight that institutional pace, or maybe not fight it, but crank it up as it becomes very necessary, particularly in your area of practice.
Yeah, I think just showing the data.
Mm.
Essentially, when you make an argument that by doing this, we're going to save, patient's life,
Hmm.
uh, and to the health system, you can also say that okay, by doing that, you're going to treat more patients, you're going to be doing more procedures. Essentially, when you speak with the health system, one of the things that they look for is the ROI. By doing that, if we're spending money uh, for this kind of solution, but at the same time we're able to recognize the patient and offer them the timely treatment, patient wins because now we are able to help them in a timely manner. Institution wins because now they're able to recognize those patients sooner, so that they don't have to bear the burden of late presentation of those diseases, longer length of stays, and things like that. It's a win-win situation. So I think you just have to present those data, and whenever you speak to the folks, speak to them in the language that they understand.
Sure. Yeah. And patient centered care is definitely much more than a buzzword. And so, yeah, how do you approach improving the patient experience, especially when it comes to the high stakes procedures?
Patient care is essentially the center of how we treat patients at Baptist Health South Florida, and essentially we want to give them the Amazon experience or the Ritz-Carlton kind of the patient experience. And whenever we make decision, we essentially have the patient at the center and see how we can make that patient's life easier. Give you an example. When came at Baptist, patients were being treated with the valvular heart disease. They used to have a multiple office visit and multiple touch point for testing and evaluation. So, give an example that if the patient has severe aortic stenosis or severe mitral regurgitation, they would be referred by a general cardiologist to interventional cardiologist who does the valve replacement. They'll see the patient, then they would order a test such as a CAT scan and a cardiac catheterization. Both of them would be done on a different days. Then they would see a surgeon who would also give their opinion, and then the patient would be discussed in a meeting and then would schedule for the procedure. So this whole thing, I explain you that the mortality is 50% at 2 years. So in this whole process, we're actually wasting about 3 months to 6 months in this whole process, plus the patients being thrown from one place to the other place, and they'll have to multiple other visits to a different specialist. So how we looked at is we looked at the patient's journey, and we were like, how can we make this patient's life easier?
Right.
So we were like, okay, if the patients get referred to cardiologists, why cannot a nurse navigator come in and speak to the patient and tell them that okay, you need a cardiac catheterization and the CAT scan, educate that patient that why it's being needed, both of them done on the same day, so they don't have to go for two different visits for two different evaluation, but have the CAT scan and then have the cardiac catheterization. So now we reduce two visit and we converted it into one, and now those evaluation is done. Interventional cardiologist and the surgeon can evaluate the patient on the same day.
Nice.
Now they have the information also. They can see that information before they meet the patient, discuss among themselves, and see if the catheter based valve replacement or repair is a suitable option or a surgery is a suitable option. And then have surgeon and the interventional cardiologist evaluate the patient at the same time. And once the patient leave that office visit, they can have the scheduling of that procedure. So now we reduce that multiple visit to just two visit, and then patient is scheduled for the procedure. And by doing that, we reduce that recognizing the issue to the treatment to less than 28 days, and we also improve patient's comfort. So just looking at the patient journey
Right.
and how can we make that patient's journey better. So that's how we look at improving the patient's experience. And things like Ignite Care that I mentioned, also things like Darcy simulation, which actually simulate the whole procedure. And when the patient sees that, I mean, imagine how powerful it is that I can show them that, okay, this is how the valve's gonna land in your anatomy, and it doesn't look like that we're gonna have any issues from the procedure standpoint. And if we recognize that we're going to have some sort of issue, then I can show them that, okay, the reason why I think you shouldn't have the catheter-based valve replacement or repair is because if we do that, we are looking at some lethal complication or adverse event, and I think you are better suited. If you're candidate for surgical approach, that should be a better approach. So now I sort of played a role in giving them an informed decision making
Sure.
tool also.
Yeah, no, it's great to see that image and just the empowerment of the patient through that technology. Zooming out, so from a leadership perspective, what metrics or indicators do you focus on to measure program success and identify areas for improvement?
Yeah. So for the program success, the outcome speaks the loudest, right? The biggest indicator for me is what's the mortality rate of the procedure, right? So if I'm leading the structural heart program, the biggest indicator I look at is the in-hospital mortality of that particular procedure. So that's the biggest indicator of the program success. And the other success, which is not looked upon, is making sure that once the patient is diagnosed, what's the diagnosis to the treatment days or time frame?
Right.
Because we want to make sure that once the patient's referred to you with some problem, we want to make sure that that problem is addressed within a month.
Yep.
Because if it goes beyond the month, then I'm actually exposing that patient of some adverse event. So this is a different way of looking at it, right? Because most of the people are focused on the procedural outcome.
Right.
But you also have to understand, if we don't do the procedure, how much risk that we are exposing that patient to, right? So one, I look at the procedural's outcome, and the other one, I also make sure that the procedures are being offered in a timely manner.
And how do you use technology to track these metrics?
So technologies like Ignite would help us in terms of that diagnosis to the treatment phase, because then we can essentially know that when was that echocardiogram or the diagnostic imaging done, and for how long it's been taking for that patient to be referred to a specialist, and from referral to the treatment, how much time it's been taking. So one is making sure that once the patient has been diagnosis to the referral time is monitored, and we use tools like Ignite to help with that process. And Cerner probably would have also have some tools where we can identify that when is uh, the echocardiogram was done, and when the patient is being referred to a specialist, and when after a specialist referral, when the procedure is being done.
Awesome. All right. Well, I'm going to keep zooming out and we'll just talk about looking ahead. So, what excites you most about the future of structural heart care, technology, and what advice would you give to emerging leaders entering the space?
So what excites me is the first decade of structural heart space focused on the aortic valve and the mitral valve. The aortic valve therapy, the transcatheter aortic valve replacement, is already well established. It's to the point, standard of care also in patients more than 80 years of age. Between 65 to 80 years of age, it's more of a shared decision making, and less than 65 years of age, we still offer them surgical valve replacement. So that has cemented its place in sort of standard of care. In the mitral valve space, also we have tools like transcatheter edge-to-edge repair with MitraClip or Pascal device, and that's been also well established in uh, the therapy domain for the functional mitral regurgitation, which is basically mitral regurgitation due to the weak heart muscle. And for those patients who are prohibitive risk in primary mitral regurgitation, where the mitral regurgitation is because of the issue of the mitral valve. But now there are trials and therapy being coming out, and now in the commercial phase is the tricuspid valve repair and the replacement. Tricuspid valve, which is the valve on the right side of the heart between the right atrium and the right ventricle, used to be considered as a forgotten valve because we wouldn't do anything to this valve. But now there's a repair therapy which is available commercially called TriClip by Abbott, and there's a valve which is also FDA approved and in the commercial market also from Edwards Life Science, which is Evoke. So I think next phase would be that tricuspid valve intervention, and the other things which are coming is the heart failure related monitoring, because as we age now there are a lot of folks are suffering from heart failure, and in the heart failure domain the biggest tool we need is sort of keeping them out of the hospital. And how do we do that is having the remote monitoring of this patient. So the sensor based solutions are also coming in where we can monitor these patients um, while they're still at their home and living their life. Because in the past, how we have treated patients is episodic treatment, where patient sees the doctor every 3 months, 6 months, and the decisions are being made based on those 3 months, 6 months visit. But what about during those 3 months? How can we monitor those patients during those 3 months? So monitoring through sensor-based solutions would also be coming into the play in the next decade. And it's an exciting time to be in the structural heart space. What early 2090s did to the interventional cardiology space by having a stent. When the stent came out in 90s, that essentially changed the landscape of how blockages in the heart artery or coronary artery disease are being treated. And now the last decade was essentially how the valves were being treated, and now it's becoming mainstream, and there are more structural heart therapies are coming out for the other valves also, and also catheter-based solution to treat the heart failure also. And my recommendation to the young generation would be, cardiology is an amazing field, especially the structural heart field, and it's like having that instant gratification where your day is never, there's no end of an excitement in my 4 days I'm in the cath lab and one day I'm in the office. So 4 days I'm doing those procedures and helping those patients, and on day of the office I'm actually seeing the patient before the procedure, after the procedures, and is the most gratifying feel that I have when I see those patients after the procedures and how I've improved their life. And with the artificial intelligence coming into the healthcare space, I can only imagine that what next decade would bring to this field.
Wow, amazing. And I have to say, everyone wants to live in the moment now. Being present is probably one of the most common catchphrases of our time. And here you've just put it out there. If you go into structural heart, you have the opportunity to be present, and not only be present, but you're going to be saving lives. Amazing. And you know what I'll also say, just in closing, is yeah, we talk about AI in this show a lot, and how technology can have a major effect. But even like listening to you talk about how the stent, these innovations that can really just move the needle, or create these leaps, are truly fascinating, and they're not just limited to the digital world, even though that's where we seem to put most of our attention these days. But there are incredible innovations in healthcare, like the stent that come along and they change the course of history. So, Dr. Patel, thank you so much for your time today, for just being very engaging and really helping us understand what drives you, what you love doing, helping us understand more about structural heart technology, and really just seeing how rich and rewarding the career and leadership that you've exhibited truly is on a personal level.
Thank you, Tyler. Indeed, it was my pleasure to share, my experience with you folks. And thank you so much for, having me on the show.
Yeah, thank you for coming on, Dr. Patel. We really appreciated all of your insight and experience.
Thanks again for listening to Quick Hits, a healthcare technology podcast for healthcare technology professionals. Follow us on Spotify or Apple Podcasts, and don't forget to reach out to us with feedback, suggestions, or even people in the healthcare technology industry you think we should interview. Send an email to quickhits@healthdatamovers.com.